which if that was asked to me, I would have been I don't know most of the answers for those questions. So that is the level of difficulty this exams were, and the overall pass rates in this exams were not that great as well. Okay, there were lots and lots of failures this time. So people here, if you had failed in the exams, don't feel bad. Okay, it is like, I would say the overall pass percentage, I would say, was not more than 60%, including trainees and non-trainees. And when it comes to non-trainees, it is very, very, very low. So don't feel bad, and we can all work together for the next exams. Right. So today's topic is HPB surgery. Okay. So again, HPB surgery is one of a very, very common topics where you will get definitely 2 or 3 scenarios in your exams. So the common areas which as a non-HPB trainee you need to be aware is in everything around gallbladder. Okay, everything around gallbladder, gallstones. That's one area you need to focus upon. And the second thing is everything around pancreatitis. Everything in depth you need to know. So these are the 2 things you will be expected. And the third thing which you need to know is the various liver SOLs, the space occupying lesions in the liver. They might start with an imaging, and they can go they might ask you, identify what is this, and you need to know how various lesions look differently in the CT or MR. So these are the common areas. If they go further, you need to know further things like the 3 cancers, the pancreatic cancer, the cholangiocarcinoma, and the liver cancers of anything, and colorectal metastasis. These are second in line, which you need to know. But the first topic, whichever I told, you need to know in depth. Yeah. Right. So let me start. Let me start my Viva probably with Mohammed Bargash. Are you happy?
Yeah.
Okay, let me just give me a minute. Let me open my all right. Okay. So Mohammed, so you are the consultant on call, okay, and you are doing a general surgery clinic, okay, and you have a patient referred to you by your GP, okay, a 45-year-old female, okay, who is known to have hypertension and diabetes, okay, has been having some abdominal discomfort. The GP has done an ultrasound scan which shows gallstones. Okay, so patient is coming to you. Okay, how will you proceed in this situation?
So I will start by taking a focused history about her gallstones, including the type of pain and the amount of pain. Is there any sickness or vomiting? Is it linked with any type of food or anything? Then I will proceed with taking some blood tests, including.
So how will you know? How will you know that this patient's symptoms are specific to gallstones?
So first of all, I will look at the patient type. So she is a female. I will see if she is fatty, like in the 40s and 50s. Then I will proceed to the symptoms itself. So is it linked to fatty diet? Is it in the right upper quadrant? Is it referred to the back? Is the what is relieving? What is there any relieving factors? On examination, I will examine her abdomen.
Fine. And what is the typical pain of a gallstone?
Typical pain of gallstone, usually it's epigastric or right upper quadrant pain, which is referred to the back. Sometimes it's referred to the back. Usually it comes after eating fatty meal, and pain of gallstone. So biliary pain, it doesn't stay for more than 6 hours. If it stays more than 6 hours, then we will suspect acute cholecystitis.
Okay, what do you understand by the term biliary colic?
So my understanding is this is like a historical kind of name. Now they call it biliary pain because sometimes it's not colicky in nature, and sometimes it's because of the irritation of the irritation of the peritoneum around this area.
Okay, fine.
And as I mentioned, it's less than 6 hours. It's in the epigastric right upper quadrant, referred to the back after fatty meal.
Fine. So imagine in this patient, you feel that patient has a typical history of a gallstone. Okay.
Yeah.
What will you do next?
So I will I will examine the patient. I'll make sure that she doesn't have any previous scars, any previous any hernia, any problem in her tummy. I'll ask her if she has had any, again, as I mentioned, focused history. Following that, I will check her blood tests, including her LFTs, to make sure that she doesn't have any obstructive kind of symptoms, obstructive kind of picture on the blood tests.
Fine.
I will
So
check that.
you do all the blood tests. Blood tests are within normal limits. You look at the ultrasound scan. Okay. So how does a stone appear in an ultrasound scan?
So the stone appears in the ultrasound scan with acoustic shadow. So multiple stones will have shadows which differentiated from the polyps, gallbladder polyps, because gallbladder polyp doesn't have shadow. There is another difference, which is gallstones can move when you put the patient on his side, on the right side or left side, but gallbladder polyp stays on the same position.
That's fine. What are the types of gallstones you are aware of?
So there are pigment stones, and there are cholesterol stones, and there are mixed stones.
Which is the common type of stone?
Cholesterol stones.
Okay, fine.
Or
so
mixed,
what do you,
I don't remember. So.
What is brown stones? Where do you see that?
They come with the brown and black. I think the brown ones are linked to infection. I don't remember.
Okay, what do you understand by the term primary bile duct stones in a post-cholecystectomy patient?
So primary bile duct stones, these are a rare kind of entity. I think they happen in 1 to 3% of patients, and they appear only, they start from the bile duct. They are not from the gallbladder and then they escape through the duct. They start from the bile duct itself.
How do you differentiate, say a patient had a cholecystectomy, coming now with obstructive jaundice, okay? How do you differentiate that whether it is a retained bile duct stone or it is a primary bile duct stone?
I'm not sure.
Okay. What do you understand by the term mucocele of gallbladder?
So mucocele of the gallbladder is a gallbladder which had gallstones, and one of the gallstones obstructed the cystic duct, and then the gallbladder started filling with bile, then mucus, and it's like acute cholecystitis, complication of acute cholecystitis, and the gallbladder started getting distended more and more. This is liable for infection, and if it got infected, it will turn into emphysema of the gallbladder.
Fine. What do you understand by the term white bile?
So white bile is actually when in the mucocele of the gallbladder, when it starts forming mucus rather than it contains mucus rather than bile, because there is no bile going in. So it starts filling with mucus, and they call this white bile.
Fine. Let me move on to the next person and then we will come back. Yeah. Mohan, you want to continue, Mohan?
Yeah. Right.
Yep. Okay. So imagine the same patient. Okay. So you are explaining that you obviously have a typical feature of a gallstone and you're telling that you need cholecystectomy. Okay. But the patient says that I don't want surgery, and I have been told that there are some medical management for gallstones.
Okay.
How will you deal with this situation?
Right. First of all, I will explain to her the gallstones. What are the potential problems of not doing the surgery, and what are the possible complications of not doing the surgery? And also, since she has raised the different type of medical management, I will tell her that there's not much evidence for medical management for a patient who have a gallstone, especially she's symptomatic. She's having a symptomatic gallstone rather than a asymptomatic gallstone. So I will reiterate to her that the most important thing is to remove the gallbladder itself rather than the stones, because the gallbladder itself is a diseased gallbladder. So just removing the stones might not be the answer for her problem.
So imagine, so in which patient will you consider medical management for gallstones then?
In patients who are not fit for surgery, or they have cholesterol stones which are very small.
Okay, so imagine this patient. So how will you know that this patient has a cholesterol stone or a pigment stone? So this patient just has biliary colic. She never had cholecystitis. Yeah, and patient is so. What is the success rate of a medical management of the gallstone?
Right, the percentage itself, I'm not very sure what is the success rate. What I know is the success rate is very low. And if we're going to, one of the ways to differentiate whether it's a cholesterol stone or a pigmented stone, one of the things is we can actually run a blood test for her and see whether her lipid profile, whether the lipid profiles are high, and that could actually give an answer whether this is possible or cholesterol stones.
Fine. So when we tell about the medical management, what do you understand by medical? How do you manage a gallstone medically?
The thing that I know that they usually give for medical management is the acid. I can't remember the exact name. Urodoxycholic acid.
Ursodeoxycholic acid, Ursocol. Yeah. Okay. So in which specific situations do you think, what are the prerequisites for using medical management? So imagine this patient is so very adamant, okay, that I don't want surgery. Okay. I am happy to accept the risk. And she is asking for medical management. Do you think any patient who doesn't, who's not willing for surgery, do you think that the medical management will work? Or if not, in which patients it will work?
From my opinion, I think the medical management will not work. And I will explain to her that the chances of it working is extremely low. And if she is adamant of trying a medical management, first of all, I think I will see whether this is a possible cholesterol stones. And if it's a possible cholesterol stone, yes, because patient doesn't want a surgery, but maybe I'll give her a trial of this medication, but I will keep on my follow-up, and I will see her back after that, in a certain time, and see whether she has any relief of the symptoms. And if there's no relief of the symptom, then I think I will re-counsel her for surgery.
Okay, so how does this ursodeoxycholic acid work?
All right, I'm not sure. Sorry,
okay,
I'm not sure.
And as I told, what are all the indications? For example, leave this patient, yeah? So you were telling some cholesterol stone. So what other indications where you think that medical management might work?
I'm not sure.
Okay, and do you know, I was repeatedly asking about what are all the prerequisites, okay, before we start on medical management. One is obviously cholesterol stones alone will work, okay, pigment stones or calcified stones or brown stones doesn't work. Anything else you need to be aware of before deciding that this medical management would work or not?
If I have to say, I think I'm not very sure about the size of the stones. Whether sometimes the bigger stones might not. If the small stones might work, but I'm not sure.
Okay, let me move to the next person, Rashid. Can you continue the same? What are all the prerequisites before we decide that the medical management might work, apart from the cholesterol stones and the size of the stones? Can you unmute yourself, please?
Yeah. So the first prerequisite will be it should not be a Mersey syndrome patient.
Why?
That can lead to mucocele and empyema formation. The stone will still be there.
Of course, patient who is very symptomatic, we are not going to put the patient on medical management. Yeah, patients who are asymptomatic or with mild discomfort, some dyspepsia, or the group of patient obviously will think about medical management. Yeah.
Okay.
Anything else?
So there are two forms of medical management. One is by taking medication like ursodeoxycholic acid, and there are other things reported in literature like ESWL. For ESWL, you have to have a patent duct in case that the stones are broken down into tiny fragments. There should be a space through which the ducts, stones can fall down and come out through the common bile duct into the bowel. So
Excellent.
that
So
should be,
one is a patent cystic duct which is needed for ESWL, as you rightly told. What else is needed for ESWL for it to work?
I'll pass.
Okay, so this is about ESWL you told. What about medical management? Again, obviously we need a patent cystic duct for this medical management to work, because the ursodeoxycholic acid, this ursocol is basically bile acid. It's nothing else. Okay, so this bile acid should be in the bile for it to work. So obviously, if the cystic duct is not patent, this ursodeoxycholic acid is not going to reach the gallbladder to do its job. So what else? So one is a patent cystic duct, which you are told. Anything else you are aware of which you think is necessary for functioning of ursodeoxycholic acid?
No, I can't think of. Sorry.
Fine. What do you understand by the term oral cholecystogram?
Oral cholecystogram, also known as gram chole test. So it's not being done now, but it's of historical importance, in which a dye was given orally, and it used to be absorbed and was secreted by the liver into the gallbladder.
So what is the main idea of this test? What do they try to see?
It tests the contractility of the gallbladder.
Anything else? One is contractility of the gallbladder. Second thing,
Sphincter of Oddi, and plus any stones in the duct.
Yeah. So obviously it tests the patency of the cystic duct, first of all.
Yeah.
And
security capability as well.
Exactly. So it assesses the function of the liver, looks at the patency of the cystic duct.
Yeah.
And okay, imagine you do a oral cholecystogram and you see that the gallbladder is not picked up. What does it mean? What are the differential diagnoses?
The differential diagnosis, the patient might have a gallbladder removed.
Very good. Excellent.
That's fine. So secondly, if I can remember, if the duct is blocked, the dye won't be accumulated in the gallbladder.
Yes. So if the duct is blocked, what are all the differential diagnoses then? In which situations the ducts are blocked? When I say duct, the cystic duct, I mean.
The cystic duct, yeah.
So how can you, my question is, how can you diagnose acute cholecystitis by oral cholecystogram?
No, I'll pass.
Okay, fine. Let me move on to Nisha. You want to continue, Nisha? Nisha, you there? Okay, let me move to Khalid.
Sorry, I was trying to unmute.
Okay, tell me, Nisha. So what will be the finding in oral cholecystogram to say that it is acute cholecystitis? You there, Nisha?
I'm here, sorry.
Oh, okay. Because you were calm, I thought you went off. Any idea?
I mean, there's no way to I'm answering a question with another question. There's no way to say the gallbladder wall will look thickened and all.
Yeah, means oral cholecystogram, you won't be able to see the gallbladder wall. Okay. What finding in oral cholecystogram will be diagnostic of acute cholecystitis?
Pass, I'm not sure.
Okay, fine. So going on to the medical management. Okay. So imagine your patient is coming with mild dyspepsia. You have decided to start on ursodeoxycholic acid. Do you know how much dose we will give and how long do you give and how do you follow up those patients?
No, I have no idea about that either.
Anyone else? Yes, Rashid.
I think it's 300 or 600 milligrams.
Okay, you give 300 or 600 milligrams. So how long does it work? How long you need to give?
So I don't use it regularly, but I have known people taking it for 6 months and even more.
Okay, after 6 months?
No.
Okay.
I don't know. I haven't followed up, this patient for long. So.
Right. Okay, let me stop here. Okay, let me quickly revise all these things. Okay.
Yeah.
So gallstones, very, very important. Yeah. The typical feature of a gallstone is dyspepsia. Dyspepsia is a big collective terminology which includes symptoms like biliary colic, bloating sensation, heartburn, everything. Okay. So when patient can present with this, or they can present with the typical biliary colic type of a pain, which is a typical epigastric pain, usually starts 2 hours after food. It is a severe, intense pain, sometimes radiating to back, and usually it stays at least for 45 minutes to 1 hour minimum. Yeah, so that is why the term biliary colic is misnomer. Okay, it is not a colic pain at all. Okay, and the various types of stones are cholesterol stones, black stones, brown stones, and or cholesterol stones and pigmented stones, and mixed stones. These are the 3 things. Okay. The most common type is a mixed stone. Most of the cholesterol stones are also has some pigments. So mixed stones are the common. If you say cholesterol versus pigment stones, cholesterol stones are more commoner than the pigment stones. Okay. The pure pigment stones can be black stones or brown stones. The black stones are usually seen in hemolytic anemia situations, and brown stones are generally a primary bile duct stones, which is secondary to bile duct infection and stuff, cholangitis and stuff. Okay, so mucocele and pyocele, I think everyone might know. So going on to the medical management, although the medical management is not commonly practiced, okay, there are many centers still which advocate medical management in specific situations. Okay, the indications for medical management for gallstones is you cannot give medical management for patients who are extremely symptomatic. Okay, so this is given only for patients who are mildly symptomatic. Okay, so medical management is not an indication for patient who is not fit for surgery. Obviously not. It's not going to do anything. Okay, so it is only for people who are mildly symptomatic. Secondly, they should have cholesterol stones. Okay, they should have cholesterol stones alone, where the ursocol can work. Okay, and the usual indication is usually the stone size. So basically, the ursodeoxycholic acid works on the surface of the stones. So, when we have smaller stones, okay, and increased number of stones, it works better rather than one big stone. Okay, that is why centers where they use medical management, they try to do an ESWL initially to make it small granules, and then they give the ursocol. Okay, the problem with ursocol is, as I told, one is it works only with cholesterol stones. Second thing is you need to have a patent cystic duct, and the third thing is you should have a functioning gallbladder. Okay, so the ursocol needs to go, and they should also have a terminal ileum. Okay, because this ursocol is absorbed as an intrahepatic circulation. It goes through the bile duct secreted through the liver, and then it needs to be concentrated in the gallbladder. So the concentrating functioning of the gallbladder should be intact, and the gallbladder should function properly for the stones, whichever is fragmented or dissolved, to come out. So these are all the prerequisites, and usually we give it for at least 2 to 2.5 years. Minimum duration is 2 years. Okay, so and all these patients are followed up with an ultrasound scan every 6 months. Okay, and once the stones completely disappear in the gallbladder, still we continue giving ursocol for another 6 months. So the drug needs to be given 6 months following the complete dissolution of the stones. Okay, and it can be the adjuncts to the medical management is the ESWL, where you break the stones and you allow it to function. So in centers where they do medical management, okay, obviously before starting the medical management, obviously we need to know whether the cystic duct is patent or not and the gallbladder is functioning or not. In those situations, we need to do some functional assessment of the gallbladders, which is usually done by oral cholecystogram, or what is the other test which is commonly done now? Anyone else?
HIDA scan.
HIDA scan, obviously. So the feature of acute cholecystitis in HIDA scan or oral cholecystogram is acute cholecystitis. How it works, obviously, cystic duct closes and then inflammation happens in the gallbladder. Yeah. So obviously the dye in the oral cholecystogram or the radioactive tracer doesn't enter the gallbladder at all. So if the gallbladder is not visualized in an oral cholecystogram or a HIDA scan, it is either a cystic duct stone or the patient has acute cholecystitis. Okay. It is exactly like how a rectal, a barium enema was done in the past to diagnose acute appendicitis. When a barium enema is given, and when in a patient with right iliac fossa pain, and when barium enema is given, and when the appendix is not filled, that is one of the diagnostic feature of acute appendicitis. Similarly, in an oral cholecystogram or a HIDA scan, when the gallbladder is not picked up, in a symptomatic patient, we diagnose acute cholecystitis by not visualizing the gallbladder. Okay. Any doubts so far? Okay, good. Let me move on. Okay. Let me go with Amir, you want to continue?
Okay.
Yes, Amir. Now the same patient comes to you, okay, but with a slightly different symptoms, okay. So the GP thinks that patient has a typical biliary colic, okay. He has done an ultrasound scan, okay, but he couldn't see any gallstones. But patient is often coming to the GP with epigastric pain, okay. So hence the GP has referred this patient to you. How are you going to proceed in this situation?
Okay, I take my thorough history again, although I have the history from the GP, and do the examination, check whether there is any other cause for the biliary colic, for the epigastric pain. Let's say it might be hernia, it might be peptic ulcer, or duodenal ulcer. Then I would ask about the medical history, any smoking, for example, use of non-steroidals or steroids.
So you get all this history, and you obviously don't find anything which contributes to patient's pain.
Yes, and the pain is typical of gallstones pain, biliary colic.
That is what you think. Yeah, exactly like what we told. Patient says that I'm developing pain in the epigastric region, like half an hour, 45 minutes after taking food, and it stays for 2-3 hours. So this is what patient says.
Yeah, so I would keep in mind a differential diagnosis of biliary dyskinesia, maybe. Yes,
okay.
and I would. Did the GP do an ultrasound or not?
The patient has an ultrasound scan, which is showing a normal gallbladder.
Yes, so I would think of doing some HIDA scan. If other. First, I might do an X-ray actually, starting. Maybe some stones are radio opaque, although it's rare. After that, I might do a CT scan.
So how commonly you identify a stone in an X-ray which is not picked up in an ultrasound scan?
10% maybe.
No, I think it's 0. Yeah. So ultrasound scan doesn't work with whether the stones are calcified or not, isn't it?
Okay.
Yeah.
Yes.
Fine. Okay. So any other test you want to do in this patient before you embark on HIDA scan?
Yeah, CT scan, MRI, MRCP also.
No, what you will do, you cannot write everything to the patient and tell do everything and come. You need to go step by step. Yeah.
Okay. I'll start with the liver function test and general urine examination to see whether there are any bile pigments in urine. Yes.
Everything is, you do blood tests, all the blood tests are normal.
Yes. So then I have only the imaging. The imaging that I have is the MRCP, CT scan, ERCP. This is interventional. I would leave it till the end. Also,
what will you do in the order now? So this patient, you ordered for blood test. Patient is coming back to you. Blood tests are normal. What next?
Yes, I would do the imaging.
What imaging?
I would do the MRI.
MRI abdomen, you mean?
Yes.
Okay. So when you write MRI abdomen request, okay, So what are you
Yeah.
going to write as an indication for this MRI abdomen?
I think I would do the MRCP better.
Okay.
That's what yes. And OGD also I might request.
So you will ask for an OGD and MRCP, yeah?
Yes.
So when you ask for MRCP, what
Mhm.
what is the indication you will write?
Indication typical biliary colic, and ultrasound doesn't show a stone.
So when ultrasound doesn't show any stone and LFTs are normal, do you think a radiologist would accept an MRCP first of all?
I'm not sure.
Okay, fine.
Okay. Yeah.
So you do an MRCP. Okay, you have fought with radiologists telling that I am the consultant. You just do what I say. Okay,
Yeah.
I am in touch for the patient. MRCP is done. MRCP is normal.
Yeah. And then I would do the HIDA scan.
Okay. So
Yes.
what do you look for in the HIDA scan?
It can show the biliary dyskinesia.
So what is biliary dyskinesia?
It's also there is hyperplastic sphincter of Oddi, another cause of this pain. Yes.
So first tell me, what is biliary dyskinesia?
Biliary dyskinesia is abnormal, inappropriate contraction in the wall of the gallbladder and biliary tree.
Okay, fine.
Yeah.
So are you aware of any criteria based on which the diagnosis of biliary dyskinesia is made?
No, I'm not. I don't remember them. I read them before, but now it's out of my mind. I haven't.
What is Rome 4 criteria for diagnosing biliary dyskinesia?
I'm not sure.
Okay, so you told that you want to do HIDA scan. Yeah, what will you see in HIDA scan to make a diagnosis of biliary dyskinesia?
HIDA scan can show the function of the gallbladder and the biliary tree. So
what exactly you will look for to say that patient has. So what is HIDA scan, first of all? Tell about that.
It's a radioisotope scan. And it shows the whole process of absorption of the radioisotope into biliary tree and the excretion of it. And it can visualize the whole, gallbladder and bile duct until the radioisotope passes to the GIT.
So obviously here what happens is a radioisotope is tagged to a dye, isn't it? A tracer, yeah? So what tracer is used in HIDA?
It's HIDA and AODIDA. I think it's technetium.
Technetium tagged with what? Technetium is the radioisotope. It is tagged with what?
I don't remember.
You know what is mebrofenin?
No, this is the first time I hear about this.
So what does HIDA stands for?
Again, I'm not sure. I remember it's HIDA and AODIDA. That's from my previous studying. I'm not a biliary surgeon.
Okay, fine. My next question is, so I told that this particular specific dye is used, yeah, in this HIDA. Why do they want to use this dye? Why can't they use dye like, say, a methylene blue can be used or something else could be used? Why specifically a particular agent is used for this?
Because it's absorbed by the liver, metabolized by the liver, and excreted into the biliary tree.
Excellent, very good. So it is completely taken by the liver, completely excreted by the liver, yeah, with no absorption. Yeah, nothing is retained. Yeah. So keeping this in mind, how do you diagnose biliary dyskinesia?
I'm not sure. Yeah.
Okay,
but gallbladder wouldn't appear. I mean, you wouldn't see the gallbladder when there is.
So is it gallbladder won't be seen or something else? The gallbladder obviously has to be seen. Yeah, the biliary dyskinesia, you know, the gallbladder functioning is a problem. Yeah.
Yes.
So what do you understand by the term ejection fraction of the gallbladder?
Mm. I believe it would be lower than normal.
Yeah. So
Yeah.
do you know what is the value for that before you diagnose as biliary dyskinesia?
I'm not sure.
All right. Okay. So we will stop here for a minute. Okay.
Yes.
So again, another common scenario which we can get in our day-to-day clinical practice is a patient presenting with a typical biliary colic or a dyspepsia kind of a pain, and ultrasound not showing any stones. Obviously, in the exam, because this is a HPB topic, obviously Amir has thought about biliary dyskinesia. But in the exam, obviously biliary dyskinesia won't come into your mind straightforward, or in your clinical setting, you're not going to think of biliary dyskinesia straightforward. So you have to think about all the possible causes. So you need to tell that the various possible causes are starting from medical cause, surgical cause. Obviously, the surgical causes would be, say, gastritis, drug-induced chronic pancreatitis, and then still a biliary colic, which is not a stone, which is not seen in the ultrasound. The other possibility is still they can have sludge. Yeah, still they can have sludge, and with no obvious stone can still cause biliary colic kind of. So obviously these patients, when you proceed, you will do all the basic blood tests first of all, and then if at all, if the patient had only one ultrasound scan before, obviously you need to do another ultrasound scan to look for any stones or sludge in the gallbladder. If there is a sludge or a stone in the gallbladder in the second ultrasound scan, obviously that would explain the patient's symptom. If ultrasound scan doesn't show anything, then probably the next investigation which any one of us would do would be a CT scan. Yeah. So MRI, unfortunately, MRI abdomen is not a diagnostic investigation of choice for an unknown etiology. For example, if you think something at the pancreas, you can ask for an MRI pancreas. If you think something about liver, you ask about MRI liver. If you want to think about bowels, you can ask for MRI enterography. But for a diagnostic purpose, CT scan with contrast has more sensitivity in identifying the cause for it than an MR, because with MRI, with every organs, we have a specific protocol which needs to be booked. So we cannot we can still ask for an MRI abdomen with contrast, but that follows a CT scan, obviously. So you will do a CT scan first, and obviously an OGD next. If that is negative, then probably you might ask for an MRI abdomen. If that is negative, then obviously you will think about biliary dyskinesia. So the functional disorders of the gallbladder are diagnosed based on exclusion. You need to exclude all other common problems before you think about functional problems of the gallbladder. So there are certain criteria, the most common criteria for most of the functional disorders, starting from esophagus to colon to biliary tract, is the Rome-4 criteria. Okay, so Rome-4 criteria is basically patient should have a typical biliary colic pain. Okay, there should be an there should be an absence of a structural problem within the gallbladder, and there should be an absence of gallstones with normal liver function test. Okay, so these are the things which falls under Rome-4 criteria. And then HIDA scan, which is very, very common question in the exams. You might get questions on what is HIDA, what contrast is used, why this contrast is used in HIDA, what are all the clinical indications where HIDA is used, okay, and what do you look for in HIDA. Okay, so basically in a HIDA, a tracer is tagged with a radioisotope. And it is taken up completely by, so in a particular time, the liver will take up fully. Following that, the liver should start excreting. Then you will see the bile duct and the gallbladder. And in a certain period of time, the liver and the bile duct and the gallbladder should have emptied completely. And you should see the same tracer in the intestine, and then it goes down. Okay. So based on this, we do something called as a gallbladder ejection fraction. Okay, if the basically normal gallbladder ejection fraction should be 100%. Okay, if it is less than 40 or less than 35 to 40%, then the diagnosis of biliary dyskinesia is made. Okay, so this is how you diagnose biliary dyskinesia. Okay, or the other test which you can do is, again, that is specific for Sphincter of Oddi dysfunction, which is cholecystokinin CCK induced MRCP, which can be done. Yeah. Good. Mohan, any doubts, Mohan?
Yeah, I just want to ask, you know, the scenario that you gave earlier, patient comes in gallbladder symptoms, but there's no gallstones. Would I be wrong if I bring it, my first investigation will be an OGD
Of
and
course.
subsequently other tests? Will I be wrong to
Means
say that?
I means obviously when you say OGD, okay, with an ultrasound scan, yeah. So patient had an ultrasound scan which is not showing anything. Patient coming with epigastric pain. I think we go from non-invasive to more invasive. Then obviously I think CT has replaced most of the investigation at the moment. I would go with an order of CT scan to start with. And then, or you can have CT and an OGD rather than just an OGD. That's what I feel. But you wouldn't be wrong if you say that means obviously this patient needs an OGD before doing going ahead with HIDA scan or an MRI abdomen.
All right.
Yeah.
Okay. Thanks.
Amir,
Thanks.
Yes.
Amir, you want to ask? Yes.
Yeah, it's you said the other test is cholecystokinin induced MRCP
Yes.
and the radioisotope. I forgot the name you mentioned.
It's basically HIDA stands for hepatic immunodiacetic acid. That is called HIDA. Okay, and the name for this dye is called mebrofenin. It's called mebrofenin. Yeah.
Oh, thank you.
No worries. Naveed, Sumro.
Yes, this time they asked the question the same. There was no any gallstone in a pregnant woman. So what is the next we would say to them?
So in a pregnant woman, again, yeah. So imagine the same situation happens in a pregnant woman. Yeah. Obviously, ultrasound, if it didn't show a stone, and if LFTs are normal, and if patient is not that symptomatic, we can continue the patient on conservative management with painkillers and stuff. Because pregnancy is one situation where everything slows down. Yeah, the gallbladder functioning slows down, the cholesterol levels in this is very, very high. So patient getting biliary colic kind of pain is quite common. Yeah, but still, if ultrasound is not showing anything and you still have a problem, I think in a pregnancy situation, I would go with MRI abdomen rather than a CT abdomen to start with. And if MRI abdomen shows a stone or obviously finds anything else, then you will go ahead with planning whatever you need. So the present recommendation is, say, a pregnant lady, which I'll come back actually. We are having a scenario on that. So in a pregnant lady, obviously after ultrasound, I would think of MRI than a CT scan.
Okay, perfect. That's
Yeah.
right. Thank you. Thank you.
Rashid?
If there are no gallstones on the ultrasound and on the CT, and even on MRCP, so can we label it as microlithiasis causing pain? And what's the role of endoscopic ultrasound? Then when does that come into play?
So again, I would say the biliary microlithiasis, okay, bile microlithiasis is more commoner than biliary dyskinesia.
Yeah.
Okay. So in a patient where you don't see an ultrasound, you don't have an ultrasound showing a stone or an MRI showing a stone, I would not, means it is less likely that it could be because of microlithiasis. But where I would chase that is a patient presenting with pancreatitis. Okay, patient presenting with pancreatitis, ultrasound not showing any stone, there is no CBD stone, patient is not an alcoholic. In that situation, obviously, I will try to do an endoscopic ultrasound to look for any CBD stones or gravel in the CBD, or I would go further to ask for a biliary cytology and biliary aspiration to look for microlithiasis in order to identify microlithiasis. Just for a symptom of a biliary colic, if ultrasound and MRCP is not showing anything, I would not go and do a biliary cannulation to take bile sample to look for microlithiasis. In that situation, I will go for HIDA first and then think of the rest.
Okay.
Yeah, does it make sense?
Yeah, it does. Thank you.
Yeah. Good. Right. Let me continue. Whom should I? Naveed, you want to continue, Naveed? Naveed?
Sorry, I'm doing something in the middle of. I didn't know that.
Do you want to or not?
If a 5 minute, okay, that's fine.
No, that's fine. Let me go to another candidate and come back when you are free. Henry, you want to continue, Henry?
Hello.
Yes, Henry.
How
So
are you?
I am good. How are you?
Good, thank you.
Good. Okay, fine. So Henry, so again, a similar kind of a situation. Okay, you are doing a general surgery clinic and you have a patient, okay, who has come to you, okay, with recurrent attacks of epigastric pain, okay, and slightly deranged LFTs.
Okay.
How will you manage this patient? So you have taken the history from the patient, okay. The patient is young, okay, no constitutional symptoms, just presenting with symptoms of biliary colic, okay, gone to a GP, they have done an ultrasound scan, which didn't show any stones, but LFTs are slightly deranged. Bilirubin is slightly high, okay, I would say bilirubin of 54, okay, and ALT, AST in around 80s and 90s.
Okay. So if the ultrasound hasn't shown anything, then next imaging modality for me would be an MRI, MRCP.
Mm-hmm. So why do you want so when you told MRI and MRCP, you want MRCP or MRI or both?
I want an MRCP.
You want MRCP. So what do you look for in MRCP?
MRCP, I'll be looking for any stones that may not have shown up on the ultrasound. That may be because there was bowel gas in the way or because of the patient's body habitus. So it's not always imaging modality. And I suppose I'd be looking for any other sort of biliary structural problems, maybe like a stricture of the bile duct or something like that that could cause sort of biliary colic type pain.
Fine. That's fine. Okay, so you do an MRCP. MRCP comes out as normal bile duct, no bile duct stones. Okay, gallbladder doesn't show any stones.
Okay. The bilirubin, do we know? Is it more of a conjugated or unconjugated?
Yes, so it is. So obviously, when you ask for LFTs, okay, you don't get conjugated or unconjugated bilirubin stock. Yeah, you would just have bilirubin alone. Yeah. So would you like to ask again?
Yeah.
You want to
so
have
I would like to know. Yeah, I would like to know if it's a conjugated or unconjugated.
What if the unconjugated bilirubin is high? What will you think of?
So I'll be thinking of a pre-hepatic cause for the raised bilirubin. So perhaps a hemolysis condition.
How will you go forward in that situation? So say indirect bilirubin is high, then the direct. What next?
So the unconjugated is high.
Yeah.
So I would want to do some more hematological investigations. So I'd want to send off like a blood film, hematinics.
Fine. Obviously, you do this blood films, you do peripheral smear, you will ask hematologist to see. But imagine the conjugated bilirubin is high or the direct bilirubin is high in the split.
So that would suggest a post-hepatic cause. So again, I'm looking at a possible biliary obstruction, which for whatever reason is not showing up on the ultrasound or the MRI. So the next investigation could be a ERCP.
So do you think that if you ask a ERCP person with a normal MRCP, do you think that they'll do an ERCP? Is it not? So do you think it is worth doing an ERCP? What is the incidence of post-ERCP pancreatitis?
probably high enough for it to not be done without good reason.
Exactly. So the risk outweighs the benefit, obviously, in this situation when MRC, and I'm pretty sure no gastroenterologist will do that when MRCP is not showing anything.
You could do maybe a percutaneous like transhepatic cholangiogram. I feel like
Is it not even more worse than an ERCP?
I'm digging a hole here.
What will you do? Say imagine it's a very common scenario. Okay, a patient presenting with abdominal pain, deranged LFT suggestive of an obstructive picture. MRCP is not showing anything. What will you think of most commonly? Most commonly, what will you think of? We get these patients every day.
Some sort of stricture.
Before stricture, what is common? Obviously, it's a passed out stone. Yeah. If the stone is passed out, you will have this picture. Yeah. So obviously, in that situation, what you will do is you will think of a passed out stone. You will repeat blood tests to see if it is improving or not. Obviously, if the blood tests are all improving, you will assume that it is a passed out stone and you will discharge the patient or plan whatever next it is. Imagine you thought it's a passed out stone and you discharge the patient and the LFTs improve. Okay, subsequently. Patient comes back again within a month with same symptoms and with same LFTs. What will you do?
I repeat the same investigations again. So start with ultrasound.
You repeat an ultrasound, repeat an MRCP, which is not showing stones again.
So again, what are the bloods doing?
Same obstructive picture, slightly elevated bilirubin, conjugated bilirubin is high, and ALT, AST is slightly high.
So I'll repeat the bloods again and see if they're improving and see if this is possibly another, stone that we've missed.
So if you get such a patient in your clinical practice, okay, what will you do? Patient coming second time with same picture and you don't know what to do. What will you do next?
I'm just wondering whether I should image the pancreas to see if there's anything going on there that could be causing the conjugated bilirubin.
So what additional test apart from MRCP you would like to do now?
So CT pancreas.
Okay, you do a CT pancreas, okay, which is very good investigation to think about here, and CT pancreas is normal.
Well, this would be one that I'll be discussing at the benign MDT.
Excellent. So this is the situation. Obviously, we need to approach the benign MDT because you have done everything and you don't know what is the thing. And I think it is going beyond your expertise, being whatever special means. Of course, if you're a HPB specialist, you need to think of obviously. But as a general surgeon, you need to put this to an MDT to think what. So now with this background, what are all the possibilities it could be? What are all the rare diagnoses it could be?
Rare diagnosis. I mean, I'm thinking, something like a Maritzi, but you would still expect to see that on the imaging. Well, I mean, whether there's a stone that is.
Okay, let me continue with the next person. Yeah, Mazin Mohammed, you want to continue, Mazin? Mazin, you there? He's not switching on the camera. That's fine. Okay. Who is next? Who wants to continue?
Hey, sorry, are you asking for me?
No, Mazin Mohammed. Okay, that is fine. Let me continue with who wants to continue? Who has not answered before? Khalid, you want to continue, Khalid?
Yeah, okay, please. Yeah, no problem.
Naveed, tell me, Naveed.
Yeah, okay, of course.
Were you listening to the scenarios?
Yeah, I listened. That the patient came back again with
yes.
Yeah,
He
and
came
then
back
it's young,
again.
quite young patient, isn't it?
Yeah, so quite young patient comes back again with same problems. This is a third admission. Okay, of course you will put up in the MDT, but what will you think of? What could be the possibilities?
This oh yeah, this could be something benign strictures, or maybe some dyskinesia of the patients, or maybe some Mersey syndrome. Could
No,
possible.
obviously, Mersey syndrome you would be seeing in the MRCP, isn't it?
Yes.
The MRCP is normal.
Okay.
The bile duct is not dilated.
Okay.
Enzymes are deranged. Okay. CT pancreas normal. There is no head of pancreas lesion or anything. What next?
What is my next will be, I would talk to my gastroenterology colleague to having a EUS will be more efficient, because it will exclude the microlithasis of the yeah, this will be my next choice of investigation.
Yeah, so you do an EUS, and EUS also shows no stones.
All right. Okay, so again, and then next is a HIDA scan, which is looking for the functional problem of the gallbladder.
So what are all the functional problems of the bile duct or the gallbladder you are aware of?
This is dyskinesia, or another problem that is periampullary area as well, where there's a diverticulum also lies around that area. So these are the two more.
So how come a diverticulum can lead to a functional problem?
That is a valve functioning.
It's not diverticulum. What is that? Whatever you're trying to tell is right, but what is it called?
No, I don't know.
It's a sphincter of Oddi dysfunction. Yeah.
Oh yeah, yes.
So sphincter of Oddi dysfunction. So what is sphincter of Oddi dysfunction?
Sphincter of Oddi, that is a common bile duct and the pancreatic duct joins together, opened into the D2, and the sphincter maintains the biliary flow.
Yeah. So do you know what is the basal sphincter pressure normally?
No.
And when will you diagnose sphincter of Oddi dysfunction? Any idea?
I think there was something kind of contrast study was doing, and
yeah, one is a contrast study. It's not a contrast study, but a kind of functional assessment, which is called as the CCK induced MRCP. That is when you do that CCK induced MRCP. What else?
OGD also could be looked into that.
Anything else specifically to see? Obviously, when you say sphincter of Oddi dysfunction, you are dealing with some pressures in the sphincter, isn't it?
Yeah.
So how can you assess the pressure in the sphincter?
As a manometry as well.
Exactly. So you can do a sphincter of Oddi manometry measurement. Okay. Do you know how many types of sphincter of Oddi dysfunction are there?
No, it's very detailed. It's only many.
That's fine. So imagine you put up this patient to a benign MDT, and they are suspecting sphincter of Oddi dysfunction, and they're doing an sphincter manometry, and they're diagnosing it as sphincter of Oddi dysfunction. What's the treatment for sphincter of Oddi dysfunction?
One, as I remember, there could be a stenting, could be a buttocks injection. These are the two I know.
What simple thing? What is the most common thing which they do?
I think putting a stent.
No, less than that. So stent will you put in, and then obviously stent cannot be permanent there. You need to take it out, isn't it?
ERCP and
sphincterotomy. Sphincterotomy is the most common thing which we do. Do you know what is meant by Nardi's test? N-A-R-D-I, Nardi's test.
Yeah, I heard, I read it a long time ago, but I'm not on it now.
Fine. Okay. Fine. We'll stop here. Amir, you want to? Is it a question or you want to answer something? You were raising your hands. Yes, Amir. Tell me, Amir. You need to unmute yourself.
Can we use calcium channel blockers in those patients or not?
Yeah, of course. See, calcium channel blockers. These things are done in situations where you cannot relieve the high pressures there. Okay, unlike symptoms, unlike things like achalasia cardia or esophagus, means what is a nutcracker esophagus and stuff, where the amount of intervention required is too much to sort out the problems, where a lot of medical managements are there. So in a sphincter of Oddi dysfunction, it is a very tiny tissue which is hypertensive. Yeah, and doing a sphincterotomy is much easier, and it relieves the symptoms earlier. Then obviously means, of course, when patients continues to have problems in spite of a sphincterotomy, then obviously it is less likely that it is a sphincter of Oddi dysfunction. So the theoretical answer is calcium channel blockers would work, but practically will we use it or not is less likely, because we have a lot of curative measures for that. Okay, so this is tell me, Amir. Tell me.
Also, I thought about Gilbert disease. These things they came into my mind about the differential.
Exactly. So Gilbert syndrome is definitely one. Definitely one.
Yes.
Yes. Very good. Very good. So sphincter of Oddi dysfunction, patients with sphincter of Oddi dysfunction, they exactly present like this. Okay. So they will have recurrent presentations with epigastric pain or biliary colic end of pain. You'll do an ultrasound, you won't see anything. You'll do a CT, you won't see anything. LFTs are in a kind of an obstructive picture, and then you do an MRCP, it won't, and then usually it settles down. Again, they come with the same kind of a problem, or they can present with recurrent pancreatitis sometimes. So these are always again thinking of sphincter of Oddi dysfunction is again by exclusion. You need to exclude all other possibilities, and having this in mind, you proceed further and look into the various tests which we do. And the diagnostic test to diagnose sphincter of Oddi dysfunction is the sphincter manometry, and the basal pressure of the sphincter of Oddi is 10 millimeters of mercury. Okay, that's the basal pressure. When the basal pressure is more than 35, okay, then we suspect sphincter of Oddi dysfunction. Okay, again, for diagnosing sphincter of Oddi dysfunction, we have the Rome 4 criteria. There are 3 types of sphincter of Oddi dysfunction: type 1, type 2, and type 3. Okay, so basically there are 3 things which we look for. So one is the typical biliary pain, and the 2 is there shouldn't be any stones or structural abnormalities, and 3 is deranged LFTs. These are the 3 things we consider when making the diagnosis of sphincter of Oddi dysfunction. So in type 1, you will have all the 3 of it. Okay, you will have deranged LFTs, you will have no structural abnormalities or stones, and third is a biliary pain. In type 2, you will have biliary pain as constant and one of the other 2. In type 3, you will just have biliary pain, but LFTs are normal and there's no structural, there is no transaminitis or anything else. You just have biliary pain. So based on which you classify the type 1, type 2, type 3. And the treatment obviously is you need to do a sphincterotomy. That's the best treatment of choice for sphincter of Oddi dysfunction. Okay. Any questions? Good. Right. Yes, Mohammed.
Sorry, I might have missed that. It's a question from the first kind of Viva. You asked me during the questions about how to differentiate between the like retained stone or a stone which is formed. Sorry if I miss it.
So it is just based on the timings. Okay. So if a patient presents within a year after cholecystectomy with obstructive jaundice and a stone in the bile duct, we assume that it's a retained stone. Okay. Anything more than 1 year, we assume that it is a primary biliary stone. It's just the timings. Yeah. Good. Amir?
Yes, you mentioned Nardi's test.
Oh, yeah.
Yeah.
So Nardi's test is a historical test. Okay. We don't do, obviously. So we give 2 drugs. We give morphine and we give neostigmine. Okay. We give morphine and neostigmine. So basically, morphine will contract the gallbladder and neostigmine will contract the sphincter. Okay. And you see whether patient develops biliary pain, typical of a biliary colic. Okay. So when this Nardi's test is positive, okay, then patient has a functional biliary colic pain. Okay, it is just a historical. So you give morphine and neostigmine. So one compresses, one tries to drain the gallbladder, other increases the pressure in the ampulla. Okay, so it increases the pressure to which that it is completely closed and patient will have biliary colic pain. Normally, even with neostigmine, the pressure should not go this much and it should open up. Okay, but in sphincter of Oddi dysfunction patient, it doesn't open up and patient will immediately develop biliary colic. Okay.
Okay, thank you so much. And the pressure, you said it's 10 millimeter mercury, the normal?
That's a normal, and anything more than 35 to 40 basal pressure, you suspect sphincter of Oddi dysfunction.
Thank you so much.
Right. Let us move on. Who wants to take next? No one? Anyone else wants to take next? Okay, so if not, I'm going to come round again. Okay, let me start with Mohammed Bargesh. Yes, Mohammed. Now again, the same kind of a scenario. Okay, patient presenting to you in your clinic. Okay, patient presenting with a typical of a biliary colic. Okay, and patient is having normal LFTs. Okay, you are doing an ultrasound scan. Ultrasound scan is not showing gallstones. Okay, so you repeat another ultrasound scan which is not showing any gallstones. Okay, you do a CT abdomen. Okay, CT scan again showing nothing. Okay, so you do an MRCP now. Okay, so MRCP is showing this. Let me share. Can you see?
No.
No? I think it is. Yeah. Can you see now?
Yes, I can. The picture is small. Let me have a look.
Is it? Picture is small.
No, it's small to me, so I'm enlarging it, so it's fine.
Okay.
So that's an MRCP.
Mm-hmm.
So I can see dilated, so that's dilated, not CBD, that's dilated the common hepatic duct, or CBD. No, that's choledochal cyst.
Now you first read the MRCP.
Okay, so I can see, so that's single slice coronal MRCP or MRI scan of like MRCP, and it shows to me there is no filling defect. There is dilatation of the whole common bile duct, which raised a concern for me to be a choledochal cyst.
Very good. Okay, so what is choledochal cyst?
It's a dilatation of the a common bile duct, or the bile ducts. It's of 4 types. There is type 1, which is fusiform in shape. Type 2 is secular. No, sorry, 5 types. So it's 5, not 4. So so type 1 is fusiform dilatation. Type 2 secular kind of dilatation coming from the side of the CBD. Type 3 is it's sorry, I can't remember.
Okay, type 4.
Type 4 intrahepatic and extrahepatic part of the bile duct, and type 5 is only intrahepatic.
Okay.
The Caroli syndrome.
Okay, and what is this classification called?
Sorry, I can't remember.
Okay, so what is the classic presentation of a choledochal cyst patient?
So the patient come with pain, mass, and jaundice.
Okay, very good. And so among the types, whichever you told, which is the commonest type?
Type 1.
And next common?
Type 3.
Okay, it's type 4. Okay, so fine. So what is the treatment for choledochal cyst?
If it's symptomatic, then we'll need to do excision of the cyst and then reconstruction by like hepatico-jejunostomy.
Yeah, but imagine if it is an incidental finding.
If it's an incident, I think
Incidental finding?
it will need to be removed as well because it's precancerous in rare kind of situation, like rare incidents sorry, it can be precancerous, but in a low percentage of people.
So imagine if this choledochal cyst needs to become a cancer, what cancer does it cause?
Cholangiocarcinoma.
Okay, what is the risk of cholangiocarcinoma arising from a patient with choledochal cyst?
Rare, but I don't know the percentage. It's low.
Okay, okay, and which types has the most highest chance of becoming a cancer?
Sorry, I don't know.
Okay, fine. And imagine, so if it is a type 1, obviously we exercise fully. Imagine if it is a type 5 choledochal cyst with Caroli's disease with multiple cysts. So how will you exercise those things?
So the only way is liver transplantation.
Okay, fine. So what is the pathophysiology of choledochal cyst? Why does a choledochal cyst evolve? What are the theories behind it?
I don't know.
Anything related to a junction between pancreatic duct and the biliary duct? Any idea?
No. Sorry.
All right. Okay, we'll stop here. Okay. Again, this is a very, very common scenario of having a patient presenting with biliary colic, not finding any stone, and deranged LFT, or a patient incidentally coming with an ultrasound scan showing dilated bile duct. Okay. It is very, very difficult many times, okay, to say many times what happens is they just give as a dilated bile duct. Okay. So you need, as a general surgeon, you need to be knowing what is an abnormal dilated bile duct. Okay. So the bile duct size, the normal bile duct size is less than 7 millimeters. Okay. The bile duct size physiologically goes up as we become more older. And obviously, post cholecystectomy status, the bile duct are slightly enlarged. Okay. So anything which is abnormal, for example, anything more than, say, for example, in a young patient, anything more than 7 millimeter, or in an old patient, anything more than 8 to 9 millimeters, it is an abnormal dilated bile duct, which needs to be investigated. Okay. Many times it is very, very difficult to differentiate whether it is just an abnormal dilated bile duct or a choledochal cyst. Okay. Because choledochal cyst, there is no histological evaluation, or there is no blood test to differentiate. It's all based on the imaging, whether it is choledochal cyst or a dilated bile duct. So any of these abnormal dilated bile ducts, as a general surgeon, your role is to put up in the benign HPB MDT for them to evaluate by a HPB person. Okay, so they might ask for further investigations like an MRCP or sometimes an EUS, because obviously when the bile duct is dilated, before we go to a diagnosis of choledochal cyst, we need to make sure if there is any benign biliary stricture in the distal end, or if there is an ampullary stricture, or there is a mass in the head of the pancreas, or an ampullary lesion, or a periampullary diverticulum, or a head of pancreas lesion, or a chronic pancreatitis. So it could be anything. Okay, all these things needs to be ruled out in a patient with an abnormal dilated bile duct. Next comes whether it's just a dilated bile duct or a choledochal cyst. Generally, if it is a choledochal cyst is never a uniform dilatation. It is an abnormal dilatation of a bile duct. A normal dilatation is a diffuse dilatation. In a choledochal cyst, it's an abnormal. Obviously, the main problem comes only with type 1 and type 4, where there's a fusiform dilatation of the bile duct. The rest of the types where you have a choledococele or a diverticulum or a cyst within the liver, it is easy to identify. But usually it is diagnosed by a HPB radiologist, and the recommended treatment till now is resection if possible. Okay, so especially with type 1 and type 4B, where you have only the extrahepatic disease. Okay, so all other things, for example, in type 3, where you have a choledococele, which is within the duodenal wall, obviously you cannot do a Whipple resection for a slight risk. So if the patient develops obstructive jaundice, we just do a sphincterotomy to dilate that. That's the only thing we do. But the role of surgery comes only for type 1 and type 4B, where the symptom is purely extrahepatic and the risk of cancer is high. Okay. The aim of the surgery is to resect as much or completely the abnormal bile duct. Okay, so you should start with wherever it's dilating close to the hilum up to the junction of the bile duct to the pancreatic duct. Okay, the most accepted or common theory which is given behind choledochal cyst is because of an abnormal communication between pancreatic duct and the biliary duct, which causes reflux of pancreatic juice into the bile duct. That is why when we try to do, for example, if the type 1 choledochal cyst is involving the common bile duct, common hepatic duct, and it's extending into the right and left hepatic duct, obviously we cannot be resecting fully, we cannot resect, but the aim is to resect as much as possible down where the pancreatic duct and the bile duct joins. That should be our primary aim, and proximally we can go as much as we can and resect it, and the rest of the dilated duct close to the liver can be put under surveillance. Okay, but you need to, the distal limit is, you need to dig the bile duct into the head of the pancreas. In fact, you will obviously, if possible, you can identify the bile duct pancreatic duct junction, and duct junction needs to be divided and sutured. And again, the incidence of cancer is very high in that junction. Okay, the risk of cancer is very, very high in type 1 and type 4. I wouldn't say very, very high, but type 1 and type 4, and the risk is almost 20 to 30%. 20 to 30 times more than the normal population, okay, of developing a cancer. So till now, means although now we are slightly moving towards surveillance than resection, but till now the recommended treatment is resection for a resectable choledochal cyst. And as he rightly mentioned, for type 4 disease, as long as type 5 Caroli's disease, as long as the patient is not symptomatic, we can follow them up. If patient is developing recurrent cholangitis and stuff, the only treatment is to do a transplant. Okay. Any questions?
Can you move the classification?
For Todani's classification.
Oh.
Yeah. Amir, you have raised your hands. Is it your old raised hand or the new one?
Sorry, that's already raised.
No problem.
I'll just
okay, fine.
Sorry.
Any questions in this, guys? No? Fine. Now, let us move on. Let me move to Mohan.
Yep.
Mohan, now, again, a same kind of a scenario. Patient coming to you, to your clinic, with typical of a biliary colic type of pain. LFTs are normal. Ultrasound is done, which is showing a 9 millimeter polyp in the gallbladder.
Right. Okay.
How do you manage this patient?
All right. Again, I will, once I get the focus history and with the ultrasound of a 9 millimeter polyp, if the patient is asymptomatic, I'll see whether the patient is symptomatic or asymptomatic. If the patient is asymptomatic with a 9 millimeter polyp, we can actually follow up and with a regular ultrasound, interval ultrasound, to see whether the polyp is growing in size. If it grows more than whatever 9 mm now, then she will need a elective cholecystectomy. But if the patient is symptomatic, then I will subject the patient for a cholecystectomy.
Okay, so you say that, so how will you follow up? So this patient, imagine this patient had an incidentally picked up GB polyp and it's 9 millimeter. Okay, so what is the surveillance plan?
All right, the subsequent ultrasound I will do in about 6 months' time to see whether there's any increase in the size, and if that is not raised, and then I will do another scan in about a year's time to see whether there's any interval increasement of the size.
How long?
If I'm not mistaken, you do a 6 months and also a year, and that both of them are same, then you can actually safely discharge them back to your GP. So
within a year you will discharge?
That means you will do one in 6 months and then another one in a year. So you are following up the patient is about a year and a half, then you'll discharge the patient.
Mm-hmm. Okay, fine. So is this, will you generalize this for everyone, or it is only for a specific group of patients?
It is.
So imagine I am an 80-year-old patient coming to you with the same polyp. Will it be different for a 30-year-old and an 80-year-old?
Yeah, definitely. Because if it's a 30 years old, the follow-up or the surveillance will be longer, and compared to an 80 years old patient. Mm-hmm. And also, if it's an 80 years old patient,
you told in 1.5 years you are going to discharge the patient. So it's not going to change anything, isn't it?
Yeah. And the other thing that if the 80 years old patient comes with a suspicious of a polyp, then the other thing that I need to entertain whether this is whether it's just a simple polyp or whether it's a gallbladder carcinoma. So the next thing that I would get is actually a CT scan to see whether this is just a simple polyp or something else there.
So when an ultrasound is showing a polyp, okay, you say if a patient is a 70-year-old coming to you with a 9mm polyp, you'll do a CT scan.
Yeah.
Why? How is it different from a 30-year-old having a polyp in an ultrasound scan?
Because in the risk of malignancy is higher in the 70 years old group compared to the 30 years old patient.
No, but
and
obviously ultrasound has picked up a smooth. So do you think anything else a CT scan would pick up apart from, say, imagine a CT also showing a polyp, 9mm polyp in the gallbladder? Will you do anything else more in a 70-year-old apart from doing a CT? What next you will do?
the other thing is whether, not sure whether an MRCP will be beneficial in that, because I think it will be the same thing that it's going to show. I think nothing else. It will be nothing else. I think if it shows the same thing in the CT scan, then I don't think so there's anything additionally I will be doing for this patient.
Okay, so first of all, what are the types of polyps you are aware of?
Sorry, I can't recall. I can't recall the types of polyps. The thing that I know is sorry.
Okay, imagine you have a patient, okay, who have an incidentally detected 10mm polyp.
All right.
What will you do?
All right. If this patient actually has a 10mm polyp, then I will actually subject this patient for a cholecystectomy, and I will go in the line of operative management, and I will actually explain to the patient the risk, the reason why we have to remove the polyp, because a 1 cm polyp has always a risk of it being not just a simple polyp, it might be something else there. And that will be the reason why we actually subject this patient for
I am your patient, you are explaining this to me. I'm asking, what is something else?
All right, there's always a risk of this is not just a simple polyp, it could be a precancerous lesion, so that's the reason why we have, and also the risk of, if the polyp is more than 1 cm or more than 10 mm, the risk of malignancy is higher. So that's the reason why we have to remove the polyp.
So I'm asking you, what is the risk of malignancy if it is a 10mm polyp?
The risk is low as for a cancer, but it's actually it becomes a precancerous. We treat it as a precancerous lesion.
My question is straightforward. What is the risk of cancer in a patient who has a more than 10mm polyp?
Sorry, the risk of it.
Okay, imagine you have a patient with a 20mm polyp. What will you do?
The 20mm polyp, I think again it's the same thing, that patient will need an cholecystectomy, and because of the same risk of the malignancy is higher. So again, the line of management will be still the same. I will subject this patient for a cholecystectomy.
Okay, imagine you have a patient. So you have two patients. Okay, one patient is a white patient coming from a British nationality of a 9mm polyp, and another patient you are having an patient from Indian background coming with 9mm polyp. How does it differ?
Sorry, I'm not sure.
Okay. Okay. How does it matter with a polyp with a background PSC?
The background primary sclerosing cholangitis is higher in a patient with the British patient compared to a Indian patient.
Yeah, but how does it matter? Like, say, a 9mm polyp in a patient with PSC, 9mm polyp without PSC. How is the treatment differs?
Sorry.
That's okay. That's fine. So imagine a patient presenting with, say, a patient who has a child A cirrhosis, okay, and coming to you with an ultrasound showing 6 millimeter gallbladder polyp. How will you manage?
All right. With the patient with a child's A and a 6 millimeter polyp, our surveillance the patient for the polyp, and also because it's a child's A, if in case the polyp increases in size, then this patient will be subjected for a cholecystectomy.
Okay, fine. And say, imagine the same patient coming to you, okay, and an ultrasound, instead of showing a polyp or whatever, it is showing adenomyomatosis. What will you do?
The treatment for adenomyomatosis is, if the patient is asymptomatic, then patient can be left alone and doesn't need any surgery. And if the patient is symptomatic, then it goes in the line of same like how you treat a patient with symptomatic gallstones.
Okay, what is adenomyomatosis?
It's in a okay, sorry.
Okay, fine. Right, we'll stop here. Okay, fine. Gallbladder polyp, you need to know in and out everything. Okay, very, very common gallbladder scenario, which we get in the exams and in our day-to-day practice also. Okay, so first of all, you need to know what are the types of gallbladder polyps. It could be non-neoplastic and neoplastic. So majority of the polyps which we see in an ultrasound scans are not true polyps. It's all just cholesterol deposits, which is all pseudo polyps. Okay, and because it appears like a polyp, we assume that it's a polyp and we follow up. That's why sometimes what happens is, during the follow-up scans, the polyp which was seen in the previous scan sometimes will disappear. Okay, it means that it is not a polyp at all. It's just a cholesterol deposit. Okay, so there are non-neoplastic polyps, which is like cholesterol polyps, adenomyomas, inflammatory polyps, and the true polyps are the actual adenomas of the polyp. Okay, so any patient, when they present with a gallbladder polyp, you need to segregate into two groups, whether they are a high risk group or a low risk group. So low risk group, when I say low risk group, they don't have any pre-existing risk factor for developing a gallbladder cancer. All these patients, the next scan is in 6 months, and then you follow up this patient with every year scan, okay, yearly scan up to 5 years. Okay, and at the 5 years, if in the entire 5 years, if the gallbladder polyp size is normal, it has not progressed, okay, you can discharge safely at the end of 5 years. If there's any change in the size of the polyp, okay, in between, you need to have at least 5 years of constant size of the polyp. Okay, there are 2-3 guidelines which recommends in a different way. Few guidelines says that when the polyp size is same until 5 years, you can discharge. But there are few guidelines which says, as long as the patient is fit enough to undergo surgery, they need to be followed up. This is what, there are 2 different guidelines, but the most common guidelines which we follow in the UK is 6 months and then every annual scan for 5 years. And as long as the polyp size is same until 5 years, we discharge the patient. Okay, this is for a low risk patient. For a high risk group, okay, so in a low risk group, again, the indication for surgery is anything more than 10 millimeters, we operate. Anything less than 10 millimeters, we follow up the patient. Okay, in a high risk group, so who are high risk group is patients age more than 60 years, okay, Indian ethnicity, patient with background cirrhosis, patient with background PSC, okay, and patients having sessile polyps. Okay, so these are all the patients, okay, with these patients age more than 60, Indian background and stuff. So anything more than 9 millimeters, we operate. Okay, and 6 to 9 millimeters, we follow them up. Okay, unlike the low risk group where 10 millimeters the cutoff. So here, anything more than 8 millimeters, we operate. In a patient with cirrhotic background, irrespective of the size of the gallbladder polyp, the recommendation is to offer surgery if patient has a good functional reserve. Okay, because they have a high risk of developing gallbladder cancer, because already the liver is in a chronic inflammation, which can induce inflammation into the gallbladder and cause problems. So in a cirrhotic background, irrespective of the polyp size, the recommendation is to do cholecystectomy. Okay, so the risk of cancer in a low risk group, okay, low risk group or anything, any polyp more than 10 millimeters, okay, is 40 to 70% more than the general population. Okay, 40 to 70% more than the general population. I'm not telling that a patient will develop cancer by 70%. More than the general population, it is more than 40 to 70%. Say if the general population is 2% or something, this patient will have 10% or something. If the general population is 0.1%, this patient will have a 5% risk. That's what I'm telling. So 40 to 70 times more than the general population. If it is polyp is more than 2 centimeters, there is a 100% chance that it will turn into a cancer, or 100% chance that it's already a cancer. So that is why a patient with more than 10 millimeters, we do a cholecystectomy. We need to fast track the biopsy. And if that comes as a cancer, we need to bring back the patient for a completion radical cholecystectomy. Okay. If it is more than 2 centimeters, these patients needs to be discussed in the cancer MDT, and the most often the treatment would be to do a radical cholecystectomy straight away with lymphadenectomy if it is more than 2 centimeter polyp. Okay, clear? I think we will stop with this. Yes, Mohan.
Yeah. Yes. Yeah. Thanks.
Yeah. So we will stop with this. Okay, we have been having quite a long session starting from 6 o'clock today. Okay, so I think you had a good day today. Actually, I think the day was good with discussing with the previous passed out students and this one. Just one thing I need to tell you is you don't need to stress too much. You don't need to be very anxious. Yeah. But it is, of course, it is easily said than experiencing, but just be relaxed. Okay. Try to go with the flow. As I told, I think most of you here have registered for the course, and I think few of you have not. But if you still, we have few spots left for the course. We are starting our course from coming Sunday. Okay, and because there are new because the level of knowledge expected in this recent exam was very, very high, we have decided few more things which is added to our list. So we are planning to bring in lectures for all the specialties actually, because when we discussed it so far, what we were doing is the specialty team will be discussing in depth. For the non-specialty, we'll be discussing like this. For example, in HPB, these were the scenarios which I was discussing with the non-HPB trainees. We never discuss HCC, we never discuss pancreatic cancer, we don't discuss gallbladder cancer or cholangiocarcinomas and stuff for a non-specialty people. But I think from this time, what we have done is, again, it is inappropriate when we discuss all these things. If we start discussing everything, there is no end on discussion. So what we will do is we will still discuss the things which is very essential in the form of Viva, but the non-essential things probably we will give as a lecture so that we will all know what is expected and things like that. Again, in a lecture based on the exam perspective, that's what we are planning to do. And again, this session will be available for you to access freely, and do share with your colleagues if at all anyone wants to join our course. We still have 3 or 4 spots left for the course. So all the very best. Okay, and we will all meet during the course. Yeah. Any questions? Anything else you want to ask? Yes, Rashid.
How can we get access to the library? Is it possible, or?
No. So library, so we are just giving, because we are just making it, we just revised our library. Okay. So we will be incorporating in our website tomorrow or day after. So we will let you know. I think most of you who have registered in the course are already in the Telegram group. If not, please go into the Telegram group. Everything will be discussed only in the Telegram group. Okay, we won't be discussing in the WhatsApp, okay, for the need of privacy. So we will let you know when the things are ready, which will be either tomorrow or day after. You need to log in, you need to create a username and password for yourself, okay, and then you can go in and access everything. So we have segregated the library based on the specialty, okay, which will give all the necessary guidelines and stuff, okay, and we will have a separate a folder for the videos where after 24 hours those videos will be uploaded, and this access will be provided until the day of your exams. Means when I say until the day of your exams, it will be September exams. Yeah, and then the access will be removed. So this is the plan. Okay, and again, the group is already, you were all in the group. Okay, as we told, the biggest advantage or the biggest strength of our course is this group or the chat group. Okay, anytime you hear about any conflicting things or a doubtful concept, okay, you can just put it there, and we are almost 17 to 18 people who will be happy to solve those queries. Okay, for example, a particular question you get, you don't know what to answer, or a particular scenario comes. For example, this particular patient comes in, what is the next line of management, whether to do MRI or a CT or whether to operate, what is expected in the exam. So those kind of questions will obviously come. Okay, so anything like that, just put it in the group. Again, we have segregated based on the specialty in the Telegram group. You can put it in that specialty and we can answer. We have done this in this way because before the exam, when you want to revise, you can just go into each of the specialty and you can just go through it. Yeah, that is the whole purpose. Yeah.
Okay.
Good. All right, then. Thank you so much. Have a good night. And
Thank you so much. Good
next
night.
week. Bye. Bye.
Thank
bye.
you.
Bye.
Thank you. Good night. Thank you.
Thank you.